My name is Dr. Sana Tariq. I am Junior Clinical Fellow in Cardiology at Manchester Royal Infirmary. Today, the topic of discussion is atypical Takotsubo cardiomyopathy, presenting as ST elevation myocardial infarction. Dr. Hazem Al-Shanawi is the consultant who was supervising this presentation. So I'll start with a little bit introduction about Takotsubo cardiomyopathy. So this is a type of transient left ventricular dysfunction, which is known as broken heart syndrome as well. Usually it occurs after stressful stimulus, either emotional or physical stress. And the clinical presentation, when the patients usually present, they present with chest pain, just like typical presentation of cardiac chest pain for myocardial infarction patients. And they do have ECG changes and raised troponin, so it becomes very difficult to differentiate them from the typical myocardial infarction patient. Usually history taking is very important because they have a trigger factor in their history. Most commonly, this is Takotsubo cardiomyopathy is seen in postmenopausal women, and all of the patient who present like with ACS, among them 1 to 2% of the patient usually have Takotsubo cardiomyopathy. There are a few pathophysiological mechanisms which are involved in development of Takotsubo cardiomyopathy. So the main ones are emotional stress like anxiety, grief, or anger. And then physical stress like surgery or acute illness or pain, seizures. And we had a patient who presented with like after a road traffic accident as well. So all these stimulus, the emotional stress and physical stress, they can cause activation of the hypothalamic pituitary adrenal axis, which result in catecholamine surge. So this can lead to increased release of epinephrine and norepinephrine. And then epinephrine and norepinephrine, they act on the microvascular system, and they can cause spasm in the coronary microvascular system. So this spasm leads to myocardial ischemia. And then the second mechanism is like on the similar way, these epinephrine and norepinephrine, they cause beta adrenergic overstimulation, which leads to calcium overload in the myocardium, and then it can cause myocardial stunning, which is a typical feature of Takotsubo cardiomyopathy. Like it causes transient myocardial stunning with the transient left ventricular systolic dysfunction, which recovers later on. And then there is direct catecholamine toxicity, which leads to cardiac myocyte necrosis, and then edema. So basically all of this is like sympathetic nervous system stimulated response. And all of these mechanisms like this coronary microvascular spasm and then overstimulation of the myocardial calcium overload and then myocyte toxicity, all of these mechanisms, they can lead to reduced left ventricular contractility, and then they can cause regional wall motion abnormalities similar to myocardial infarction. And then, but the only difference is that in this case, it is not confined to just one coronary artery territory. And also the myocardial dysfunction, it is very transient, like it can recover from few days to weeks. Most of the times the function returns back to the normal. So there are few types of Takotsubo cardiomyopathy. So most commonly known type is atypical Takotsubo cardiomyopathy or classical one, which is reported like in multiple journals multiple times, in which you have like typical apical ballooning. So the apex of the left ventricle, it is affected mainly in the classic Takotsubo, and then it results in apical ballooning even during the systolic phase because apex cannot contract fully. And then basal hyperkinesis, that means like the rest of the ventricle, it contracts normally, but only the apex is affected in classical pattern of Takotsubo cardiomyopathy. Then there is mid-ventricular type, which we will discuss today. Like the case which we will discuss, it has mid-ventricular type. So in this type, the mid segment of the ventricle is hypokinetic, and then apical and base, they are fine, they can contract well. There is reverse Takotsubo cardiomyopathy, in which there is like basal hypokinesia and apex is normal. And then if there is any area of focal or regional isolated dysfunction, then we call it focal Takotsubo cardiomyopathy. So the underlying mechanism, like due to the different types, like because some patients can present with apical, some patients can present with mid-ventricular pattern. It's not very clear that why they present in different variable patterns, but it is good to know that, so that we are able to diagnose the patients with who present not only with apical or classical pattern, but who present with other types. So we are presenting a case of a 65-year-old lady. She was an ex-smoker, and there was family history of heart disease, but there was no other cardiovascular risk factors like diabetes, hypertension, or dyslipidemia. Although she mentioned that she had a recent like stressful week because of her friend who was diagnosed with cancer. So she presented like a similar, like a normal, usual STEMI patient with chest pain, typical chest pain radiating to left arm and neck. And then ECG showed some ST elevation and Q waves and T wave inversion in V1 and 2. So the first troponin was 461, with the normal values being like, if it is more than 14, it is raised. So we managed her as ST elevation myocardial infarction because she had ECG changes, she had chest pain, a typical cardiac chest pain, and then there was raised troponin. So we managed her as STEMI, and she was taken to cath lab. This is her ECG. So it shows in V1 and V2, there was a subtle ST elevation with Q waves and T wave inversions. Rest of the ECG was fine. So the only striking thing was on this ECG was because she didn't have any reciprocal changes in other leads. Usually in STEMI, you expect to have some reciprocal changes in other leads. She was then taken to cath lab, and then she had coronary angiogram, which showed normal coronary arteries. So there was no flow limiting disease or no obstruction in her coronary arteries. So this initiated the thought process that why she presented with this like ECG changes, raised troponin, but with normal coronary arteries. This is our LV angiogram, which is usually done during when we do coronary angiogram, we can do an LV angiogram as well, which is just basically like a small view of the left ventricle. So it showed, so as you can see in the picture, so the picture on the right side, it shows the diastolic phase of the left ventricle, but the picture on the left, this one, it shows the systolic phase. So you can see the apex is just has a like a bird beak appearance, like a at the end, because it is contracting well, whereas the middle portion of the ventricle, it is dilated like a balloon, because this was mid-ventricular ballooning type of the Takotsubo cardiomyopathy. So it has apical sparing, like apex is not affected at all so the myocardial dysfunction is mainly around the mid-ventricle site rather than in the apex. Because in the systolic phase, we were able to demonstrate that apex was contracting fine. Next is the echocardiogram. She had the echocardiogram on day 0, like the same day when she presented, which showed mid-septal and anterior wall hypokinesia, and apex was normal, and ejection fraction was about 45%, which is like moderate impairment in her left ventricular systolic function. Even in this image, the mid-ventricular portion has like a ballooning like pattern in the LV. Then we requested cardiac MRI scan for her because there was some suspicion of Takotsubo cardiomyopathy after the LV angiogram, but we wanted to confirm it and also wanted to rule out other causes of unobstructed coronary arteries, myocardial infarction. So then she underwent cardiac MRI scan on day 5, um, which showed ejection fraction of 63%. And as you can see in cardiac MRI image, so the mid portion of the ventricle is dilated, but the apex is contracting fine on the picture on the right side. And the left side picture is showing the diastolic phase, so it's not very obvious in the diastolic phase. It's more obvious in the systolic phase when we can see that apex is contracting, but the middle portion of the LV is not contracting well, and it is causing the ballooned pattern. There is another striking feature in this cardiac MRI because so it was done 5 days after the echocardiogram, and on echocardiogram her ejection fraction was 45%, and whereas on MRI it is 63%, which is back to the normal. So this shows that there was only transient left ventricular dysfunction, which improved within the 5 days, and it further confirmed our diagnosis of the Takotsubo cardiomyopathy, which the classical feature is transient myocardial dysfunction. Then we are just discussing like the few differential diagnoses, how we ruled them out. So initial one was STEMI when she underwent coronary angiogram. So we ruled that out because she had unobstructed coronary arteries. And then second possibility can be myocarditis when the patients have normal coronary arteries and they have raised troponins. They can have some ECG changes and present with typical cardiac chest pain. So usually they have like a viral prodromal illness, like a diarrheal illness or a respiratory illness. But this patient didn't have those features in her history. And then MI with non-obstructive coronary artery disease, this is also possible, but there was no evidence of like, it is usually caused by the plaque rupture, but she had completely normal coronary arteries. There was no plaque deposition or anything. And then the final was Takotsubo cardiomyopathy. This fits in this patient because she had transient LV dysfunction, which supports Takotsubo cardiomyopathy, normal coronary arteries. And then she had an emotional triggering factor, which fits the whole scenario. So by checking all these differential diagnoses, then we ruled out them one by one, and Takotsubo cardiomyopathy was our final diagnosis. This is just for knowledge, like there is the intertag diagnostic criteria from European Heart Journal consensus document. So it states like few features. This is like a diagnostic criteria. So it states the feature of Takotsubo cardiomyopathy. So one of those is transient LV function. So this was fulfilled in our patient. Then emotional trigger. Then there is like ECG abnormalities, either ST elevation or T wave inversion, like any ischemic changes on ECG. It doesn't necessarily have to be ST elevation. Then there are elevated cardiac biomarkers and absence of infectious myocarditis, and then normal coronary artery disease, normal coronary arteries, and then predominantly it occurs in postmenopausal women. So our patient, she fulfilled all of the criteria for Takotsubo cardiomyopathy. Initially, so in terms of management and outcome, so usually the outcome is good in Takotsubo cardiomyopathy because it's transient LV dysfunction and most of the patients, they recover fully. However, some patients can have complications as well. So initially she was managed as STEMI, obviously, because we didn't know that she is a Takotsubo cardiomyopathy. Then post angiogram, she was only for supportive management. She was started on like heart failure treatment with like just for heart failure with preserved ejection fraction, like because her ejection fraction recovered back to normal within 5 days. So she was started on beta blocker, and she was a bit hypotensive, so we didn't start ACE inhibitors while she was an inpatient, but we requested the GP to start it in the community once her blood pressure improves. And then she was, during her hospital stay, she remained stable. She didn't have any further chest pain episodes, and she was stable when she was discharged. And later on, she had a follow-up appointment in which she mentioned that she has returned back to her usual normal daily activities. So there are some learning points in this presentation, like especially if the patient is woman and postmenopausal and they are presenting with ACS and you see normal coronary arteries, then this should prompt you to investigate further to look for the cause of this presentation. Then usually if we think about Takotsubo cardiomyopathy, so the first thing which comes in our mind is like apical ballooning. But this is not the case in all the patients. Some patients can have normal apex and they present with atypical variants, which we already discussed. The emotional stress is the most common participant, and the patients can also present after physical stress as well. Imaging like LV angiogram or cardiac MRI, they are very crucial for the diagnosis, especially cardiac MRI. It helps in confirming the diagnosis and ruling out other etiologies for LV dysfunction like cardiomyopathies or other etiologies. Um, and then the most important one is that Takotsubo cardiomyopathy is reversible most of the times, but follow-up helps us to see whether the patient's LV function has recovered or not, how are they doing from heart failure perspective and from their symptoms. These are just the references which I have attached for